Good evening, ladies and gentlemen. Welcome to the first of our winter series of lectures to be held here October 2025. And our first speaker, it's going to be hard to follow, I think. I mean, hard to follow for further speakers, including myself. And that's, well, I don't think he needs any introduction. Somebody might have met him a lot closer up than I am with him tonight. And that's, well, it gives you all his titles. Andrew Sim, perhaps he deserves a lot more than that. Andrew's been well, if I start giving you his life story, that'd be half of his talk away. So I hand you over to Andrew.
Okay, thank you very much, Malcolm, for that kind introduction, and thank you very much for inviting me to come and give this talk. It's one which I'm very much looking forward to sharing with you. What I'm going to try and tell you is why I became a surgeon, my journey to Stornoway, what I found when I got here, why I stayed, and what I did when I got here. But I'm going to put you out of your misery to start off with, because you may wonder about the title of my talk, not the Nutter's Tale, but the Knotter's Tale. You may think it's a nutter, but it's not. Now, a knotter is someone who ties knots. And that's an important thing for me because I earn my living for tying knots. Surgeons have to tie knots, and they even have a knot named after them, the surgeon's knot. And as you can see here, this is a very simple knot. On the first throw, you've got 2 passes. And then on the second throw, you've got 1 pass. And this gives you a very secure knot. We need knots in order to tie sutures for the skin. We need knots to tie ligatures for blood vessels. And we need knots to tie stitches attaching 2 pieces of bowel to each other. And you can imagine if these knots are not safe, then disasters can happen. So, was I a suitable person to be a knotter? Well, I actually have proof that I am a knotter. And this came from when I was a wolf cub. And I don't know how well you can see this, but this is my wolf cub membership card. And on it, it tells you that I passed my knot tying test aged 9 and the second test aged 10. And I could tie reef knots, clove hitches, and others. I didn't actually get my second star here because I failed the skipping and the telephone, which was a bit of a pest, and I've lived with that for the rest of my life. So if we now carry on, and I can try and explain why I became a surgeon, but I will tell you first of all, I did not come from a medical family. The only book that existed in my parents' house which had anything to do with medicine was the Ship Captain's Medical Guide from 1921. And the amount of medicine that's in that, which is any practical facility at all, is virtually 0. But my father bought me this book. He bought me this book, which is The Healing Knife. It's by a man called George Sava. He was a surgeon. He was an eminent surgeon, a plastic surgeon. He was an aristocratic Russian who had served in the White Russian Army, and he had saved the life of a friend of his by removing a bullet from the lining of this friend's heart. And he decided he was going to become a surgeon, and he wrote this book, which if you read, you probably can't read it that well, but the Times Literary Supplement was very effusive about what kind of a book it was, and when I read this at the age of 11, it inspired me. A few months after this, my father brought home one of these. This, as I'm sure you will all recognize, is a lancet-headed meringoplasty knife, and this is used for operating on the eardrum. I don't know why he brought it home. I don't know where he got it from, and I don't know how much it cost him, if it cost him anything. But he said to me, you try and see if you can dissect anything with this. And I did, and I dissected not this fish, but something like this, which was a gudgeon. So that was my first experience of dissection. Then, when I was 13, My brothers, Jack and Robert, gave me a Christmas present of this book, The Reluctant Surgeon, which is a book all about a man called John Hunter. This so enthused me that I read another book about him called Brother Surgeons. John Hunter was the father of scientific surgery. He was a Scotsman, he was born at Long Calderwood, just outside East Kilbride, and he went to London at the age of 20 to join his brother William, who had an anatomy school. He developed into an anatomist and surgeon, and he served in France and in Portugal as an army surgeon. He was a consultant surgeon at St George's Hospital and a surgeon to King George III. He died in the boardroom of St George's after he'd had an argument about getting two young Scotsmen into training in St George's. My father arranged for me to visit his museum of all his specimens. There were thousands of these. Unfortunately, many were destroyed in a bomb attack in the Second World War. They are housed in the Royal College of Surgeons of England, and here you can see in the middle the skeleton of the Irish giant, Charles Byrne, and surrounding this are a large number of pots which contain specimens, and you can see John Hunter's bust at the top. He had these specimens because he was working on a theory of evolution, and this was 100 years before Darwin produced his Origin of Species. So, I had obviously made up my mind that I wanted to be a surgeon. I didn't want to be a doctor, but I did want to be a surgeon. So then my journey to Stornoway started, and it started by going to medical school. And I went to medical school at St George's Hospital at Hyde Park Corner. This is the building as it was when I was there. It is now the Lanesborough Hotel. And if you want to go and stay there tonight, you won't be able to, because you'll have to stay there tomorrow night as well. And it will knock you back £2,000 to stay in that. I, for a number of years, had the address of number 1 Knightsbridge, which was quite an impressive address to have. I was interviewed by this man, Alistair Hunter, who's no relation of John Hunter. He was the dean. He was a very erudite man and a great sportsman. And when I went in, he asked me a very simple question. He said, "How do I know about Kimbolton School and Kimbolton Castle?" I'd been primed for this, and I said, "Well, sir, you probably knew that Catherine of Aragon lived in the castle and that she died there." "No, I'm not interested in that," he said. "Okay, perhaps you read that the head boy has been rusticated for saying unpleasant things about the school during the Founders' Day service." "Nope. Sim, what I want to know is what happened to the boy who ran away to join the Nazi party?" "Aha," I said. "Well, he ran away and they caught him on the south coast before he managed to get across the channel. But sadly, he was killed when he committed suicide. That was what was thought on Wimbledon Common a year later." And so I went to St George's and was there for 5 years. I qualified with MBBS, which is Bachelor of Medicine and Bachelor of Surgery in London University, in June of 1971. Unfortunately, the career advice to me was you need to become a general practitioner. That wasn't my plan. So it was obvious I was going to have to organise my own training programme. And this started in London, where I did my house officer job in St George's, as my surgical house job. My medical job was in Gloucester. I worked in the accident and emergency department in Bristol, and then was a senior house officer in Cheltenham for 18 months. But then we went to Norton in County Durham. We went and we lived in this house. This house is the Manor House in Norton. It was the house of a GP called Geoffrey Marsh, and he was a revolutionary GP because we're thinking now about 1970s, he was thinking about community nursing and community nurses doing primary care visits. This was the first kind of thing of that type. And he was doing a sabbatical, and I was going to do his locum. But why do I want to do general practice? Well, the first one was a pragmatic one, and that was I had applied for a medical officer post in the Turks and Caicos Islands. We wanted a bit of excitement, but there was no reply to that application, and I needed a job. I wanted to know whether I really needed to do surgery because I had a wife and a child, and dragging them through a training program and a career as a surgeon was something which was quite a serious undertaking. And finally, I had a problem. Why was it that GPs were unable to diagnose appendicitis? As a senior house officer, I saw lots of patients come in with a diagnosis of appendicitis, and they didn't have it. Well, during the 6 months I was there, I saw 2 patients with appendicitis. One went into the North Tees General Hospital and had a red-hot appendix removed and did very well. The other, I diagnosed acute appendicitis in his home, and the ambulance took a long time to come. And by the time the ambulance had got there, he was better. His appendicitis had settled down completely. And I suddenly realized that there are things which are different in the community than there are in hospital. But we decided that surgery was the way to go. And so I had to find a surgical job. And I went to 2 interviews. The first interview was in Cardiff, and I was interviewed by Professor Leslie Hughes, an eminent surgeon. And he told me that because I'd done general practice, there was no way in the world I was going to be a surgeon. So I may as well forget it. But I then went to Glasgow, and I was interviewed by this man, Professor Sir Andrew Watt-Kay, who was then the Chief Medical Officer for Scotland and Chief Scientist. And he was different to Les Hughes. He said he thought doing general practice was an absolute essential for people who wanted to do surgery. He had done it, and so he thought everybody should do it. And so I was appointed to a post in the Western Infirmary in Glasgow. And in 1975, I managed to pass the exams to be a Fellow of the Royal College of Physicians and Surgeons of Glasgow. While in Sir Andrew Watt-Kay's department, I did some research. First bit of research, which you can see, if I can get this pointer there, which is this one, was with gallstones and dissolving gallstones. The senior lecturer in surgery in the department at that time was a man called Colin Mackay, and we'll hear a bit more about him in the future. But he was into gallstones, and he wanted me to see if we could dissolve these. I did a study seeing whether honey was any good for healing varicose ulcers. And one day, Sir Andrew came in and said, "I want you to learn to use this instrument here. This is a Baron ligator. It applies rubber bands to hemorrhoids, and I want you to learn how to use this." So he packed me off to Birmingham, to the Department of Surgery there with Alexander Williams. And believe it or not, the man who trained me to use this instrument, his name was Andrew Crapp. Appropriate for hemorrhoids, but in fact it had 2 P's and not 1. I learned how to use this, and we did some studies. And interestingly, and I only found this out the other day, one of the people who will feature a bit later on in this talk recalls first meeting me when I was giving a talk about rubber band ligation for hemorrhoids. And the other piece of research is here. You can see this horseshoe crab. The University of Glasgow had a colony of horseshoe crabs, and the thing about them is that their blood can be used to test for a material called endotoxin. And endotoxin is something that gives people fevers. And I was working in the urology department, and we had patients who developed fevers after we put an instrument into their bladder. And we wanted to know whether or not this was endotoxin related, and sure enough it was. And that horseshoe crab had answered a question for us. Now, having done this research, it was obvious that I was interested in it, and Sir Andrew thought that I might be someone who could benefit from further research. And so I was given the opportunity to be a research fellow at Harvard Medical School. Here is my name badge on your left-hand side, and the man I worked with is here. This was Francis D. Moore, who was a doyen of American surgery. He had a particular interest in metabolism and nutrition, and that is what I worked with. And for many years after that, I did research and clinical practice which related to surgical nutrition and metabolism. I returned to Glasgow and became a senior registrar in the Glasgow Royal Infirmary, and there I got my higher surgical training certificate, and so I was now an accredited surgeon. I had become a proper knotter. Now, I worked in the Department of Surgery with Professor Sir David Carter, and he was a friend of a surgeon from here, Duncan MacLean. And he sent his senior registrars up here to do locums for Duncan when he went on holiday. And in either 1980 or 1981, I came here. And the reason I say either or is because I don't know. I haven't got any records. And there are some people in this room who I've asked if they recognise the fact that I had worked in the Lewis Hospital at that time, and they all say no. Now, that can mean a lot of things, and I don't want to go into that in too much detail, but I do know that I came here, and I know I came here because I remember it was wet, it was cold, and it was windy. I stayed in a house in Springfield Road, which was brown. It was brown inside, everything was painted brown. I did one operation I can remember, which was called a Ramsted's operation, which is an operation you do on little boys who've got pyloric stenosis, which is where the outlet to the stomach is obstructed, and I know that it worked. And I also know that I bought some venison and some Harris tweed, but I can't find any record and no one remembers me. So it must have been a pretty unmemorable event. After being a registrar there, I went to London. I became the senior lecturer in St Mary's Hospital with the really grand title of Assistant Director of the Academic Surgical Unit, and I was working with Professor Hugh Dudley. He was a difficult man to work with, but I learnt an awful lot from him. And at that time, we were thinking about risks for surgeons during operations because we knew that glove punctures occurred in 30% of operations. We knew that sharp injury with either knives or with needles occurred in between 1.5% and 6% of operations. And all of these gave the risk of transmitting viral diseases such as hepatitis B and C to the surgeon from the patient, and also bacterial infection. Now, if you look at this picture, this is a classic picture taken from a textbook of surgery by a man called Hamilton Bailey. And what this person is doing is examining an enlarged spleen. But what you will notice is that he's only got three fingers on this hand. There's his thumb, there are three fingers. He lost his index finger. He lost his index finger because it was amputated after it was poisoned when he was draining an abscess. That's the kind of risks that people had. But lurking in the sidelines at that time was HIV and AIDS. St Mary's at that time looked after almost 30% of all the AIDS and HIV patients in the United Kingdom. And I developed a large surgical practice operating on patients with the consequences of HIV and AIDS, and also for the normal conditions that these people had. We had a conference on this, and we managed to produce a book which recorded the outcome of that conference. The effect of HIV on AIDS was substantial. HIV and AIDS on surgery was substantial. It meant that we had to assess patients much more carefully. We had to know whether there was a possibility that they had become infected either by sexual activity, intravenous drug abuse, or some other way. We needed to make sure that we reduced our exposure to infectious material, and we had to reduce the use of sharp instruments, and so the introduction of things like lasers and ultrasound dissectors came in place of knives. We also had to develop a no-touch technique for operating. That was a lot of work. One day, while sitting in my office in St Mary's, this was looking out over the west of London, it was a new build for St Mary's, I received this glossy brochure telling me about a university which was developing a medical school in the United Arab Emirates. I'd never heard of the United Arab Emirates at that time. I read it and I put it in the bin. About 2 days before Christmas, I got a phone call from the Professor of Medical Education in Dundee, Ron Harden, who said to me, "Did you see that brochure we sent you about the medical school in the Emirates?" And I told him a little fib and said no. And he said, "Well, we want to consider you to be the foundation professor of surgery there." And I didn't think too hard about it, but I begrudgingly said, "Okay." And I sent him my curriculum vitae, and I didn't hear anything for 2 months. And then this letter came through the post, inviting myself and my wife to go out to the Emirates to see what we thought. Jackie said yes, but we have to go and see the pyramids first. So we did that. And we arrived, and we came across the most amazing place. It was a delightful country, they were delightful people, and it really was a no-brainer to make a decision that we were going to go there. And they offered me the job, and I accepted it. And this was the medical school that we had there, which is impressive. It was took a long time to get it built, but in the end it worked very well. I had spoken to Hugh Dudley about this, and he said, if you're going to do this, then you need to think of staying there for 9 or 10 years, because the person who sets up and develops a department of surgery is not the person who's going to run it afterwards. So you have to think about what you're going to do after that. And sure enough, another opportunity came up after 9 years to be involved in another medical school project, this time in Malaysia, with the ASEAN Sheffield Medical College. I thought because it was Sheffield it would be respectable, but it wasn't. And it fell apart in about a year. So in November 1998, I was out of a job. And I was back in the United Kingdom. We had a house in Portsoy and I was staying there. So I thought, right, I must go to Glasgow. I must go and talk to people and see what I'm going to do. The man I went to talk to was the senior lecturer who taught me about gallstones. He was now the president of the College of Physicians and Surgeons in Glasgow, and this was Colin Mackay. He knew Duncan MacLean, and he knew that Duncan MacLean needed a locum surgeon, locum consultant surgeon. So he got on the phone and he suggested from his office that I go there. And that was arranged. But as I left the room, he said something which was prophetic. He said, "You might find something interesting to do with rural surgery." I didn't think too much of it at the time, but subsequently I think we know that it meant quite a lot, and he was very observant in that. And so we now come to what I found when I came to Stornoway as a locum consultant surgeon, and I found this. I found this hospital, which was an amazing hospital. It's not the Lewis Hospital. I had dreams of going back to something like the Lewis Hospital, but it wasn't. This hospital was amazing. It had been built on time, it had been built to budget, and believe it or not, it has the largest continuously tiled roof in the whole of Europe. So to come to a hospital like that was really something quite special. And when I came, I was fortunate. 2 people made a huge impression on me when I first came. Duncan MacLean, who was the surgeon there, he'd been there since 1978. He was a delightful man to work for, and to work with, and work alongside. Ian Clark was the medical director, and again, he was a man of great courage, I think, in some of the decisions he made, but he was a delightful man to work with. The first thing he asked me to do was, and this was 2 weeks after I'd been appointed, was to go to Dalibra. I had to do locums for the consultant GP surgeon down there, and I went to Dalibra, and he said, "You're not going to have any work to do down there. You may as well play golf, bird watch, and if it's raining, just read. But if you've got time, please produce a report for me on the surgical services in Dalibra." Knowing, in fact, that Dalibra Hospital was going to close in 2001. And what I found with the surgical service was that they were doing emergency and elective operations, and these were being done by a GP surgeon and a GP anaesthetist, neither of whom had GMC or General Medical Council accreditation, but they were competent at doing what they did. Now I'm going to continue, and this is a bit out of continuity with the Dalborough and Euston Barrow story, because the Euston Barrow Hospital was due to open in 2001. It was to take over the function of Dalborough and Lochmaddy hospitals. It was going to have 29 beds, and it would provide care of the elderly, general practitioner-led acute services, midwife-led maternity services. There was an accident in the emergency department, an X-ray department, an operating theatre, and an endoscopy suite. And visiting consultant services would be provided from the Western Isles Hospital in orthopaedic surgery and the medical specialties. But there was problems looming. As I said, the old service in Dalborough, there was an emergency and elective operations service by the GP surgeon and the GP anaesthetist. But in about 2000, a tragedy happened in Edinburgh when a boy died in a dentist's chair because of an anaesthetic that he was given. And the fatal accident inquiry at that time said, and the sheriff said, that if we were going to avoid death in this circumstance, then the employment of an anaesthetist who was on the specialist register of the General Medical Council was necessary, or that person who was giving the anaesthetic was under the actual supervision of someone who was accredited. Now, as I said, our GP anaesthetist down in the Southern Isles at that time was not accredited, and it was necessary for us to provide cover for that person if they were going to give an anaesthetic, and that couldn't be done at a distance. In some ways, a surgeon can supervise at a distance, but an anaesthetist certainly can't. And so it was necessary to introduce a new service for the Euston Barrow Hospital. We had to get rid of emergency surgery down there. It couldn't be done. We could only do elective surgery, and that elective surgery needed a visiting consultant surgeon, a consultant anaesthetist, and an anaesthetic technician. There were to be bi-monthly to begin with. They later changed to monthly outpatient clinic and theatre sessions, and when these consultants were present, the GP surgeon and the GP anaesthetist were able to carry out procedures. You could imagine that this was not something that made people very happy, and we had a lot of unpleasant behaviour towards us on account of this. So that was me as a locum. But we have to now think why I stayed there. Early in 2000, NHS Western Isles advertised for a second consultant surgeon. And I wondered to myself, why have they done this? And I've again asked, particularly Sandy Matheson, who was then the chairman of the health board, why did they want a second consultant surgeon? Was it to cover Duncan McLean, or were there other reasons? And I was told quite succinctly by Sandy, remembering what Ian Clark had told me, that the health board wanted a second surgeon to cover the leaves of absence of the general practitioner surgeon in the Euston Benbecula. This was before the hospital was open. So I wasn't appointed as a second surgeon to work here solely, but to cover the GP surgeon there. So I asked myself, should I apply? Well, first of all, the most important thing was, did we want to live in the Western Isles? And after some discussion, Jackie, my wife, and I decided, yes, this is a perfectly acceptable place to live. We had travelled around and we hadn't anywhere particular to stay. But was it the right job? Was there a surgical department that I wanted to work in? Were there colleagues that I wanted to work with? And were there enough challenges to keep me happy? You may have noticed that I actually quite like challenges, and that's the kind of thing that keeps me going. So let's have a look at the surgical department, and there are one or two people in the audience here who are responsible for this. Now, I had the opportunity of working as a locum for a period of time. And we had a wonderful surgical ward. This was organised and run by two sisters, Ina Nicholson and Nana McLean. They produced a ward of very high quality. We had modern operating theatres which were well equipped and well organised by Sister Stewart. We had an outpatient department which was in many ways a delight to work in, run by Sister Morrison. And we had a very effective and dynamic accident and emergency department with Agnes Munro. There were also the support services necessary to provide the healthcare we needed. And looking at this, it's very difficult to think that you could ever find anything better than this. I know there are lots of nursing staff that I haven't mentioned in this, but they are the people who really made it a place to come and work. As I said, there were colleagues. I've mentioned Duncan McLean and Ian Clark, but there is the person who listened to my rubber van ligation research, and he's sitting at the back looking up into the air at the moment. And that is Andrew Hothersall. And to work with an anaesthetist that I had known for so many years was something which I didn't want to miss. What about the challenges? Well, this is just a short list. It's an abbreviated list of the challenges that you find in remote and rural surgery. And I won't labour on many of them, but recruitment was one, retention another. Skills maintenance, it's very difficult to maintain skills when you've got a low level of activity, and so that was something that concerned us here. Continuing and professional education and development was something which, if you're in a big city, is relatively easy to arrange. It's not so easy when you come out to a place like Stornoway. Peer appreciation and recognition was something which troubled me. Many surgeons that you find on the mainland think that surgeons that work in an environment like this are there because they can't make it on the mainland. And they either have a problem, or they're alcoholics, or they've got family difficulties, and they come here to get away from them all. Sad that people think that, because I don't agree with them on it, and it certainly wasn't true for me, and I don't think it's true for any of the people that I've worked with. Living in a remote community is not something that's for everybody. When I was interviewed, Sandy Matheson asked me, how are you going to manage living in a goldfish bowl? And he's right, it's a question you need to be able to answer. Now, I had worked in an expatriate community in the Emirates and managed that, so I didn't think it would be too difficult to work here. It is a bit odd sometimes when you're walking around the co-op and someone looks at you or smiles at you, and you think to yourself, did I do something to that person? And you can't remember the name, and you certainly can't remember what they did or what you did to them. And that is something which still lives on. And then, of course, there are requirements of your family. At the same time, the Scottish Government had put in place RURARI, which is the Remote and Rural Area Resource Initiative, which was a 4-year programme with £4 million to expend on looking at remote and rural issues. And we had funding for 3 projects: the establishment of a remote and rural surgical registry, undergraduate assessment of the impact of remote and rural surgical clinical attachments, and funding for me to support me as a surgical educational facilitator for RURARI. So it really wasn't a difficult decision to decide that I would apply for this job, and I applied for it, and I was appointed on the 1st of May 2000. So let's get on to what I did when I was here. Obviously, I did operations, and I'm not going to dwell too much on this. This is a list of some of them. On emergencies, I operated on perforated bowel, obstructed bowel, abdominal trauma, appendicitis and abscesses. As an elective surgical procedure, there were large bowel operations, cholecystectomy, mainly using keyhole surgery. Breast operations, I didn't much like, and I tried to pass those on to other people if possible. Hernia operations, varicose veins, hemorrhoids, and minor operations. So there's a variety there which you might not necessarily find elsewhere. The number of surgical procedures that we carried out here was enough, I think, to keep our skills up. If you look at the planned Western Isles Hospital ones on the far left, you will see that we were performing, certainly for the years 2003 to 2006, about 1,200 operations a year. This went up quite significantly in 2007 when we managed to employ a third surgeon, and we had an increase in the number of endoscopies. And you can see that in the second set on the left, the planned mainland operations, we weren't having to refer many people to the mainland for their surgical procedures, and we were providing a worthwhile service for the population of the Western Isles, and this applied also to emergency surgery. We did most of the emergency surgery here. We were doing approximately 2 or 3 emergency procedures every week. I was particularly keen on gastrointestinal endoscopy. I was the lead clinician for endoscopy and the lead clinician for bowel screening from August 2008 when it was introduced nationally. To be a bowel screening colonoscopist is something which you have to be specially trained for, because screening programs are looking at people who are asymptomatic. And when you've got a procedure like colonoscopy, which does have its complications, you have to be able to reduce those to a minimum. So it was necessary for me to be doing more than 150 colonoscopies a year. There had to be a 90% completion rate, which means that I had to be able to examine the whole of the large bowel on 9 out of 10 occasions. Looking at polyps, I had to be able to identify at least 20% in my endoscopies, and I had to attend and complete an accreditation course. And we were able to provide a bowel screening service here, rather than people having to go to the mainland to have this done. Cancer care was another thing which was important to me. I was the lead clinician for cancer and colorectal cancer, as well as the large bowel screening program. We had multidisciplinary meetings with Raigmore Hospital using video conferencing. This was for gastrointestinal cancer, and we had surgeons, oncologists, pathologists, radiologists, and gastroenterologists all meeting to discuss the individual management of particular patients. We also had clinicians from 2 other rural general hospitals, Fort William and Wick, along with us. We produced a series of care pathways, and I won't go into these in much detail, but these 2 pathways describe what would happen to a patient with cancer if they were going to be treated in the Western Isles Hospital, a rural general hospital, or they were going to be treated in what we called another hospital, which was a mainland. I had administrative responsibilities. I was a medical director for hospital services at a time when we had 3 medical directors in the Western Isles. We had myself as the medical director for the hospital. We had Brian Mickey, who was the medical director for the community services, and John Smith, who was the health board medical director. My particular responsibilities were to look after the hospital, and perhaps the biggest problem was that of medical staff. We had between 16 and 19 consultants, many of which were permanent but not enough, and we had long-term locums and short-term locums. Long-term locums, you're able to negotiate the National Health Service salary, and they were much cheaper than the short-term locums. The one person who was instrumental in making sure that we had the right staff is the lady who's sitting in the middle here between myself and my wife while we were in Cyprus, and that was Rhoda Morrison. She was the medical staffing officer in the Western Isles Hospital, and without her we wouldn't have been able to have the medical staff that we needed to provide the services. I was also involved in bringing in a new consultant contract, which was individual negotiations with each consultant as to what work they did. We also had to develop an out-of-hours service which was compliant for the junior doctors, bearing in mind that they had now introduced the 48-hour working time directive. I had educational responsibilities, both as formal teaching and as a supervisor. The formal teaching took place in clinical settings, on outpatient clinics, operating theatres, endoscopy suites and ward rounds. and the formal teaching occurred on a Wednesday morning when we had our business and teaching meeting. I delivered 4 times a year a 5-tutorial remote and rural healthcare course, mainly for medical undergraduates, but it could have been for anybody. I supervised a foundation year doctor, which used to be called a house officer. We were part of the basic surgical training programme of South East Scotland, so we had a regular supply of training surgeons. We had undergraduate medical students from the University of Aberdeen, and we had a number of clinical attachments who came to work in the Western Isles. But in 2004, things changed. Duncan McLean retired after 26 years working in both the Lewis Hospital and the Western Isles. This was, in many ways, a sad day for us, but it was a day in which we recognised what a great man he had been and how much he had contributed to the surgical care of patients in this area. After him, I worked with a number of different people, and here are some of them. You'll see Jean Turner there. I apologise to people for the quality of these pictures, but I haven't taken high-quality pictures of them because I don't think I recognise I'm doing the full photos. But Jean, although this picture does look a bit scatty, it actually is very characteristic of her. She was a lovely lady and a delight to work with. I also worked with Julius Gavas and Sharon Shetty for a long time, and we worked as a team of 3 surgeons for a period. But I want to make special mention of Nazir Kazi. Nazir Kazi was a surgeon who I first met in 1988 in Abu Dhabi. He set up the surgical service along with his wife, who was a pathologist in the Central Hospital in Abu Dhabi in the 1960s, 1970s, and he introduced college surgical examinations to the United Arab Emirates. He was a delightful man to work with, and he had also set up a hospital in Pakistan, which is where he came from. Unfortunately, his wasn't as successful as the one that Imran Khan had, because Imran Khan, the great cricketer, had also set up a hospital, and Nazir's was in competition. But Nazir came and worked with us, and he worked with us on numerous occasions. He was a delight to work with and a man you could always rely on. Sadly, he died aged 90 in August of this year, but he will be remembered by many people in this room as someone who contributed immensely to the care of people. In about 2003, 2004, we had David Curry as the chairman of the health board and Dick Manson as the chief executive. They had an idea that they wanted to establish an academic reality here in healthcare in the Western Isles. They had conversations with UHR about the setting up of a department of academic rural medicine, which in fact came to pass, and in June 2005 I was appointed as the Professor of Remote and Rural Medicine. And the objectives of this department was to develop educational and training courses relevant to remote and rural medicine, to seek a role in advocacy and representation of remote and rural medical communities in Scotland, promote academic exchange with those working with similar issues in other countries, and to prosecute research relevant to remote and rural medical care. But after a year, disaster struck. The health board had huge issues. These were mainly financial, but there were others as well. The health board chairman resigned, that was David Curry. The chief executive, Dick Manson, was transferred, and a management team was installed. And you can imagine that at this time of considerable disquiet, an academic department was not high on their list of priorities. And the business plan that we were planning to put before the board was shelved. However, I had a contract which allowed me to pursue academic activities as well as a clinical commitment. So this is what I tried to do. And one of the things I was involved with was this national NHS Scotland project, the Remote and Rural Steering Group. This was trying to provide a guidance for the government on how rural healthcare should develop. And I think from our point of view, in terms of hospital care, one of the most important things was this statement about the rural general hospitals. It was the first time they had ever been defined. It's actually the first time that any hospital type has been defined in the United Kingdom. And it said the Rural General Hospital undertakes the management of acute medical and surgical emergencies and is the emergency centre for the community. It includes a place of safety for mental health emergencies. It is characterised, I'm not sure about using the Z there, because this was a Scottish thing, it shouldn't have had a Z there, but anyway it did, by more advanced levels of diagnostic services than a community hospital, and it will provide a range of outpatient, stay case, inpatient and rehabilitation services. And using that definition, there are 6 rural general hospitals in Scotland. They're in Shetland, Orkney, Wick, Fort William, Oban and ourselves. And they serve populations between 20 and 30,000 and are more than 65 miles from the nearest district general hospital with a travel time of greater than 90 minutes. This was accepted by the Scottish Government and it set up an implementation group to put this in place. And this had the responsibility for producing acute hospital care pathways for rural patients. We had a services models of care pathways subgroup, which developed 16 acute care pathways, 7 in non-emergencies, 3 in emergencies, 6 in malignant disease, covering 423 different medical conditions. This has been published in the surgical part of it, has been published in the Oxford Handbook of Clinical Surgery. You see there is a chapter on remote surgery. It had care pathways like these, which dealt with how you have emergencies dealt with and how you have non-emergencies dealt with. Another set of projects we were involved with were the Northern Periphery Programme. This is a European Union developed programme which involved countries in the Northern Periphery area. These were Sweden, Norway, Finland, Scotland, Northern Ireland, the Republic of Ireland, Iceland and Greenland. And we were involved initially in 2 projects, Sustainable Health, which was electronic care and management of patients, the ATSRUA project, which was associated with transportation, the COSAFE project, which dealt with how you deal with major emergencies in remote communities, and then Recruit and Retain, which was a 1.4 million euro project which we managed from here. This Recruit and Retain project had, needless to say, recruitment and retention of people, of professional people in remote communities as its main focus of attention. The countries involved, as you can see here, are Sweden, Norway, there's Scotland, there's Iceland, there's Greenland, and we were able and allowed to recruit people from Canada as well as Northern Ireland and the Republic of Ireland. And we produced a business model with 7 steps as to how we should implement the kind of things that we needed to do to maintain recruitment and retention. This business model is available on the ResearchGate website. Not all of the activities of the Northern Periphery Programme project will work. We did have a cultural side to it. Here you can see we took our visitors to the Uri Community Heritage Centre, to the Callanish Stones, the Uriston Barra Hospital. Often our meetings were in cold places, and here you can see on the left-hand side a picture of us in northern Sweden when the temperature was minus 30 degrees centigrade, a wee bit on the chilly side. But some of our people enjoyed the warmth of the geothermal pools which you find in Iceland, and occasionally we came across people who are sort of standing, and here in Enniskillen at the end of the Recruit and Retain project, you can see Baroness Foster, who was the First Minister for Northern Ireland. We had a few publications which dealt with attitudes, careers in rural general hospitals, transportation, surgery, and locals. But my favourite paper was this one, which talked about this particular fish, the ratfish. It's a particularly unpleasant fish that lurks at the bottom of the sea, and as you can see, he has a rather nasty spine. And when fishermen try to get him out, he will attack you with this spine. I'm not sure if you can see it, but you might be able to see that there is a spine in that X-ray sticking somewhere near that person's femur, and that was near to the femoral artery. This, of all the publications we produced, is read by more people than all of the others put together. I'm going to finish this part of it, talking about the Viking Surgeons Associations, and one of the reasons for that is that the Viking Surgeons Association was in fact the brainchild of Martin Crossfield, who was a surgeon working in the Lewis Hospital here from 1969 to 1977. He had the first Viking Surgeons meeting in his house in September of 1974. I'm sure you can't read it, but on that programme there is a talk by himself, but there's also a talk by Dr. John Hay about problems with isolation in Thailand. And this was the kind of thing that the Viking surgeons used to talk about. These are Viking surgeons. These are the Orkney Viking surgeons who had arranged a meeting in Orkney. You can see they have got the appropriate helmets, and these have wings and not horns. But as we know, Vikings never had horns on their helmets. And they are what are called scalpels, these two people. We call them scalpels if they organised a Viking surgeon meeting. We held a Viking surgeon meeting here in 2005, and the Viking surgeons still continue, and the last one was in September in Inverness. And you will notice this logo. This logo first appeared here in the Western Isles, and this was one which we designed, or we can't say we designed, it was designed from here by Rona McLeod, who is a graphic design artist, and this has lasted as the logo of the Viking surgeons. You can see it in these two things. So that brings me to the end here, and it's been a privilege to have been a consultant surgeon working here with this group of people who over the years have provided surgical services, starting with Murdo Mackenzie in 1896, then going on to Norman Jameson. There was John Purvis, who only lasted 5 years because the project that he was involved in came to an end then. Martin Crossfield, Duncan McLean, and myself. And as I said, it has been a great privilege to work here. But in fact, my relationship with the Western Isles Hospital hasn't finished yet. I don't work in the solid bit of it, but I do work in 2 of the gardens. I am an official volunteer gardener. This is the highest accolade I think I've ever had in my life for the Western Isles Hospital. And we have to wait for this, but there's something about this particular slide which takes a bit of time. But no, the Rotary Club of Stornoway has taken over the management of hospital gardens here. We have the Our Hospital Garden project. This was the Rotary's 60th anniversary project. The original garden, which was the Clishan Dementia Garden, was the 60th anniversary for the National Health Service in 2008. And we have a rose and tulip garden in the courtyard in the middle, and this was opened by Ian McCauley, our Lord Lieutenant, at the time of the coronation of King Charles. So, ladies and gentlemen, I've come to the end of my talk. I couldn't have done any of this without my wife Jackie. Sadly, she passed away just over 3 years ago, but with her enthusiasm, her encouragement, it managed to carry me through this journey to Stornoway. Thank you very much.
Well, Andrew, you said you liked a challenge, and you rose to it very well tonight. Now, you're a tree surgeon rather than a...
No, I haven't acquired that, but there is someone, I think, in the room. I can see him sitting at the back there. So in the hospital garden project, we rely on his ability to bring down trees. He's sitting in the back row and he's smiling at the moment, and he is someone who is a deft hand, because these are hospital garden projects. We want to design a pathway through the little wooded area there.
Oh, yeah.
And there were some trees there. And this individual, who I shan't name, was really very enthusiastic about pulling trees down. So I'm not a tree surgeon, I'm not good enough.
So he's a bit of a lumberjack and he's all right. If anybody couldn't hear that, Andrew has the implements, as you saw very early on in the old implements I'm talking about, and he can sort you out. I think you'd have found the whole thing very fascinating, and I'm sure there would be questions around the chamber. Has anybody got anything that they would like to ask? Yes, yeah.
Good evening, Chairman. Ladies and gentlemen, Mr. Sin, thank you for a most illuminating talk on your service to the Western Isles. I have a question for you. As a cancer user stroke sufferer, did we suffer from the Chernobyl effect of 1986?
That's an interesting question, because the GP anaesthetist who was down in Dallery wrote articles saying that he thought that there was an increase in the number of cancers associated with Chernobyl. And there was work done, and nobody was ever able to prove that there was an increase. It was a rumour, it was investigated, and it was decided that no, we didn't.
Okay, thank you very much.
Can you press your button?
I don't actually have a question, but I'm here. I don't know if you remember me, Mr. Sim.
Yeah.
Yeah. You saved my life, and you let me watch my son grow up. Thank you.
Difficult to answer that. Really.
Yeah.
I'm very pleased to have had the opportunity to do so.
Helping to determine whether you were here in 1980 or 1981. My wife was in hospital in October 1981, and the surgeon who operated on her was Mr. Crichton.
Crichton, he was an obstetrician. Yeah.
Yes.
Dr. Crichton was Jack Crichton.
Would he have been there when you were there, or?
I don't know the answer to that. But you see, one of the concerns I had when I knew I was coming to the Lewis Hospital was whether or not I was going to have to do obstetric surgery, because I had the first idea how to do that. And also orthopedic surgery, which again, I hadn't had much training in. But I was very pleased to find out when I came here that there was a consultant obstetrician. I think the obstetric service here, as a consultant run thing, was brought in 1956, as far as I know. And Jack Crichton was someone who served this hospital for many, many years. And in fact, he was still working as a locum when I was medical director in the hospital. But no, I've tried to chase those records, but I've been told that I can't have access to them for 100 years. So I thought I'd probably give up on that.
His presence there was very, very, very important to the fact that my wife lived. So I just wanted to put it into context for you.
Well, Andrew, just one of the predecessors was Norman Jameson.
Yeah.
Can you tell them the story about him operating on an old fisherman? I think they'd find it quite interesting.
Yes, Jameson was an amazing man. He was a surgeon in the Lewis Hospital for 25 years, and he was well respected not only in the hospital, but within the community as well. But he told an amazing story. And it was when he was in Shetland, and what happened was, I think he fell into the sea or something.
Yeah, as a young boy. Yeah.
And as a young boy. And a fisherman pulled him out. And he noticed that this fisherman had 6 fingers on one hand. Not a very common thing, but he did have 6 fingers. And then, I don't know what happened. I think it was a trauma event that this fisherman had. And he was here. He'd come off his boat. And Norman Jameson came here. And he immediately recognized this man because he had 6 fingers. He remembered it as a child. And Norman Jameson was the kind of man who, according to repute, knew people very well. He remembered people, and they were all very fond of him because of his ability to provide very personalized services. And this was an extreme example of that. The person who'd saved his life, he saved his life in the end.
Well, I thought that would be a perfect way to end the night. Unless anybody else has got another question. Otherwise, can I say that the next lecture will be at the end of November, and it's about the old buildings of Stornoway. And I can't remember who's... Oh, it's myself. I certainly won't be up to Andrew's ability, but I shall do my best. So until we see you the last Monday of November, good night, and thank you for all for coming along. Good night.